Dr. Dalia. She will be speaking on ophthalmology cross consultation in pregnancy. She is professor in Alleppey Medical College. Over to you, Dalia.
Good morning, all of you. Pregnancy can produce changes on all the systems in a female, including the eye. And the eye changes in pregnancy can be both physiological or pathological. This is mainly because of the hormonal imbalances occurring during pregnancy, and early recognition and management is important to prevent sight-threatening complication. Obstetric complications per se can also have ophthalmic signs, and prompt recognition is important, and it is life-saving to both mother and the fetus. And the safety of common ophthalmic medications are also important. The ophthalmic changes in pregnancy can be grouped as coming into the anterior segment, posterior segment, neurophthalmic changes in pregnancy, and these are some of the certain systemic conditions which can complicate pregnancy with eye manifestations. So we'll see some of the important ones. Increased pigmentation around the eyes is, or otherwise called as melasma, is the most frequent physiological change, and for this no active intervention is required, and it fades slowly over several months after pregnancy. Coming to the cornea, the thickness of the cornea increases due to water retention in the late trimester, and the curvature of cornea can increase by 1 diopters, again because of the hormonal changes occurring. And these refractive changes resolve after pregnancy, 3 to 6 months after pregnancy. Therefore, what is important is a new spectacle, contact lens, or prescription to be given, or laser refractive surgeries should be avoided during pregnancy. And in keratoconus patients who show progression, always consider C3R prior to conception to prevent progression of ectasia during pregnancy. Corneal sensitivity decreases towards the end of pregnancy because of the increase in corneal thickness, and there is increased risk of infection, and contact lens wear is risky, and return to normal 2 months postpartum. Dry eye increases with increase in the gestational age. It is mainly evaporative, and the mechanism is the hormonal changes affecting the ocular surface, and also prolactin damaging the lacrimal acina cells. It is treated with lubricant eye drops with no adverse neonatal outcome. Lens curvature increases because of the excessive hydration and produce myopic shift, and there can also be temporary loss of accommodation. Cataract per se is rare, and if it occurs, it's congenital and genetic, and surgery is best deferred until postpartum because of the risk of anesthetic agent. Glaucoma in pregnancy, there is a physiological decrease in IOP by 2 to 3 millimeters of mercury because of the increased uveoscleral outflow and increased aqueous outflow by the hormone acting. Increased level of female sex hormones is actually neuroprotective to the optic nerve. Therefore, existing glaucoma improves during pregnancy, and the need for anti-glaucoma medication can be reduced. The IOP returned to baseline 3 months postpartum, and therefore a close follow-up is required. Most of the anti-glaucoma medications are Class C drugs by FDA. Brimondin is well tolerated throughout, but has to be stopped before delivery because of the risk of fetal apnea. Topical beta blockers is safe. Carbonic anhydrase inhibitors is the optimal choice in the 3rd trimester because of the risk of brimonidine. PG analogs has to be avoided because it crosses placental barrier and stimulate uterine contractions, causing spontaneous abortions. Those cases which are refractory to glaucoma can be taken up for surgery, but the concerns are anesthetic agents, supine positioning, post-op medications, and use of antimetabolites. Uveitis, there is a suppression of the immunity because of, and there is an increase in the cytokine levels. Then alpha fetoprotein secreted by yolk sac is actually protective to the fetus. So uveitis decreases after the 1st trimester, but postpartum it flares up. Mild cases can be treated with steroids, which is safer. Moderate to severe cases can be treated with oral steroids or other immunosuppressive agents, and these are the drugs which have to be avoided. Always counsel patients of the childbearing age having uveitis regarding the risk in pregnancy before they are started on immunosuppression treatment. Diabetic retinopathy is less common in gestational diabetes. Therefore, no regular retinopathy screening is advised in gestational diabetes. But if the patient is already diabetic becoming pregnant, type 1 and type 2 can have a progression of the retinopathy. Diabetic macular edema worsen in patients with proteinuria hypertension, and these are the risk factors as in other cases. because of the and the follow-up schedule which has to be taken up is diabetic females who are considering pregnancy, a pre-conception ocular examination, and then in the first trimester is advised. If any retinopathy is present, it is reassessed 16 to 20 weeks. But if there is a severe retinopathy present with coexisting other comorbid conditions, a close follow-up is required. Gestational diabetes, no screening is advised during pregnancy. Treatment, laser is better done pre-pregnancy. Anti-VEGFs are better avoided. If diabetic macular edema is present, you can give intravitreal steroids, and these are the indications for surgery. CSR, because of the increased level of cortisol and other hormones, is common in the third trimester, which resolves spontaneously after delivery. FFA is contraindicated, and diagnosis and follow-up is by OCT. IAS, there is an increased risk because of the hormonal change and weight gain during the antenatal period. Symptoms are as in other cases, and oral acetazolamide is class 2, which can produce teratogenic effects, so better avoided in pregnancy, especially in the first trimester. Severe symptoms and gross ONH swelling, you can have lumbar puncture or lumbar drain. If very much required, Diamox can be started in the second trimester after consultation with the obstetrician. Cranial neuropathy, 7th nerve is common, also the 6th and 4th nerve, which is common in the late pregnancy. Complete paralysis and incomplete resolution is a rule, and therefore early treatment with steroids is recommended. Spontaneous orbital hemorrhage can occur during the first trimester, during labor, and patients on anticoagulant therapy resolve spontaneously, and therefore no treatment is required. These are the systemic conditions which can complicate pregnancy with eye manifestation. 25% of preeclampsia and 50% of eclampsia patients can have visual symptoms as similar in other cases. And the most important finding in the fundus is retinal arteriolar narrowing, especially nasal to the disc, also hemorrhages and optic nerve head edema. And the severity of retinopathy is inversely related to the fetal birth weight. Acute vision loss in these patients can be because of cortical blindness of serous retinal detachment. In cortical blindness, you will get a normal fundus and pupil reaction, and the vision loss is 4 to 7 hours prior to seizure. Accelerated hypertension can produce serous retinal detachment, and the patients will regain full vision postpartum with resolution of it. 10% of preeclampsia and eclampsia patient can develop the HELP syndrome. When you're asked to see the fundus, if you see an arteriolar narrowing, you have to advise to immediate termination of pregnancy. Graves, gestational hyperthyroidism and orbitopathy can occur in 0.2% of pregnancy. Most common is Graves. The diagnosis is difficult because it alters the lab test. Treatment is by antithyroid drugs, and the teratogenicity has to be considered. Any pregnant female with complaints of headache, decreased vision, diplopia, or bitemporal hemianopia has to be investigated for pituitary adenoma, which may enlarge during pregnancy. And most of these adenomas and visual symptoms will regress postpartum. So to conclude, physiological and pathological ophthalmic manifestations are common in pregnancy. Ophthalmic manifestations can occur with obstetric complications also. Early recognition and treatment can prevent sight-threatening complications, and a multidisciplinary approach is needed to treat certain conditions. Pre-existing eye conditions has to be monitored closely during pregnancy. In cases required, preconception counseling should also be advised, and the teratogenicity of drugs are to be considered in taking decisions on treatment. Thank you.
Thank you, Dr. Dalia. Usually, majority of the signs and symptoms will reverse after delivery, following 2 to 3 months of delivery. But some changes, just like in exudative detachment of eclampsia, patient may have a residual visual loss in pregnancy. And in some situations, we get consultations because of a gestational diabetes. So Dr. Dalia has explained that gestational diabetes per se won't produce any retinopathy, but if the patient is, if the person is, before pregnancy, she was diabetic, and there is a chance of retinopathy, then close monitoring of retinopathy status is very important. Not the gestational diabetes, but a diabetic patient who is become pregnant. Majority, the symptoms and the signs will resolve after pregnancy.